It's moving.
Yes, yes, sir. Perfectly all right.
Now you are seeing the slides now.
Yes, sir.
Hello.
Yes, sir.
So can we start?
Yes, sir. Yes, sir. We can start. So, hi, good evening to all. And on behalf of ISAI Oncology, I invite Dr. K.M. Parthsarthi for today's session. And today's topic of discussion is systemic therapy options in second line ARCC and beyond. So, I welcome Dr. Parthsarthi. Please, sir, you can present your slides.
Okay. Good evening, everybody. Today's presentation is basically, we all know that what is the first line in RCC. So today, what we are going to discuss is the what is the second line after immunotherapy and the common first line treatment. So suppose you are starting with a immuno targeted combination, uh, then can we use immunotherapy again, or what are the newer options? That is what we are going to discuss in a brief presentation today. So we all know the management of advanced RCC remains a clinical challenge. The 5-year survival drops to 67% for patients with regional metastasis and 12% for those with a distant metastasis. And specialized centers have reported a 5-year survival rate as high as 23%. So if you are ideally treating a patient, you can improve the survival compared to the community standards. First line treatment, second line treatment, third line treatment, and fourth line treatment. Once you are the EMDC data showing that once you are proceeding from first line to fourth line, then the number of patients are coming down, and the prognosis and the PFS is also coming down, just like ovarian cancer and the other cancers. So it is important to give the best treatment option to earlier lines, so that the more and more patients are receiving the best treatment. So,
Sir, I'm sorry to interrupt you, sir. Your slides are not moving, sir.
It is not moving.
We are still at first slide only.
Okay. Where is this? Now you are seeing?
Yes, sir.
Okay, this is a slide I have presented last. So now it is moving now.
Yeah, now I can. Yeah, yes.
Okay, there is a lag because of the internet connectivity issues. So therapeutic biological pathways for targeted treatments. This is a very important slide. You can see that where these targeted molecules are going to act. So we all know that the downstream pathway of tumorigenesis and advanced RCC, it is available in all standard textbooks. So as a student, you have to see the MET pathway, AXL, VEGFR, PDGF pathways, and all those things, and HIF, mTOR, and the downstream pathway. Even now, most of our patients receive sunitinib and pazopanib in the first line setting, and cabozantinib is currently available in India, so that second line option, and now it is also approved with nivolumab in the first line option also. So how to choose all these molecules, that is what we are going to discuss. And what is the ideal first line approach? Targeted continuum VEGF inhibition, or using a combination of VEGF or mTOR inhibition, or immunotherapy alone in the second line. What are the third line options? So these are all very confusing right now, because we have got a lot of molecules. Now it is changing now?
Yes, sir.
Okay. So this is a very busy slide. It's a summary of key clinical trials after first line. So after first line, sorafenib was compared with a placebo. There was a PFS benefit, but there was no OS benefit. Everolimus, again the control arm was placebo. PFS benefit was there. Hazard ratio 0.33. Again no OS benefit. Axitinib was compared with sorafenib. There was a PFS benefit, no OS benefit. Tivosanib, that is a newer molecule, so that is also compared with sorafenib. Again, there was a PFS benefit, but no OS benefit. What about nivolumab? Nivolumab was compared with the then second line, that is everolimus. There is an OS benefit, but there was no PFS benefit. And cabozantinib, again compared with everolimus, there was a PFS benefit as well as an OS benefit. And lenvatinib and everolimus, that is a very exciting combination. VEGF and mTOR inhibitor compared with everolimus, there is an OS PFS benefit as well as an OS benefit. Lenvatinib, again compared with everolimus, there was neither PFS and OS benefit. So this slide we can see the comparator arm and the test arm. Axitinib with against sorafenib, nivolumab with everolimus, cabozantinib with everolimus, lenvatinib with plus everolimus versus everolimus alone. So you can see that response rate first you have to see axitinib. Nowadays we are using it in the first line, so probably it is no longer very relevant. Nivolumab, it is relevant because probably we are not using nivolumab in the first line unless you are using it along with a cabazitaxel or nivo-ipi combination. You can see the response rate of nivolumab alone is 22%. Cabazitaxel alone is 17%. Nivo everolimus combination is 35%. What about the PFS? PFS in the nivolumab alone arm is 4.6 months, and the cabazitaxel 7.4 months, and the lenvatinib everolimus combination is 12.8 months. OS nivolumab, very impressive OS benefit, 25 months, and cabazitaxel alone is 21.4 months, and lenvatinib everolimus, that is also very impressive, 25.5 months. And what about the dose reduction? Here, though, since it's a combination, everolimus and lenvatinib, around 71% had dose reductions. Dose reduction due to adverse events, it is 24%. Toxicity, you can see that grade 3 toxicity was seen in 57% of the combination lenva everolimus arm, and grade 4 toxicity is around 14, around 14% in the combination arm. So it's a slightly more toxic regimen, but you can see that both the PFS and OS is very much higher compared to the other regimen, though the cross trial comparison will be difficult and should not be done ideally. What about the next slide? Yes, you can see the different arms, different studies. Here the lenva and everolimus arm, you can see that it is the most impressive, 14.6 months compared to the for convenience we are not discussing the everolimus alone arm here, but you can see lenvatinib alone arm we are not discussing. So the lighter blue compared with the deeper blue, you can see there is a wide separation of the curves, 14.6 months versus 5.5 months. And here cabazitaxel alone 7.4 months versus 3.8 months. That is also an acceptable option if you have not used cabazitaxel in the first line. And what about nivolumab alone? Nivolumab is, you can see that there is no PFS benefit, but there is an OS benefit. The curves are overlapping, so that is that can be expected when you are using an immunotherapy. There may not be a PFS, rapid shrinkage of the tumor, but like other immunotherapy studies, there can be an OS benefit. So what are the logical questions a medical oncology practicing physician or a student will ask? Has it improved the clinical outcome versus an active treatment? Lenvatinib, everolimus combination, cabazitaxel and nivolumab, they have passed that first hurdle. So the next question is, does it improve response rate, OS and PFS? So we have already seen that nivolumab is not improving the PFS. So nivolumab is out. So we have got two winners here, lenvatinib and everolimus and cabazitaxel. So we will discuss the winner combination lenvatinib and everolimus in the second line. slightly more detail, and at the end we will discuss two more studies here. We all know that lenvatinib is a combined VEGF and FGFR inhibitor. It's a multi-targeted molecule. And you can see in this study that it has got a slightly wider action compared to sorafenib, the first generation TKI. You can see in this thing is that it has got a better PDGFR inhibition and wider action. So what about everolimus? Everolimus is as an mTOR inhibitor, induces cell cancer death. Inhibition of angiogenesis is there, and it inhibits the downstream pathway. So what are the downstream pathways? S6 Ki and 4E BP downstream pathway is inhibited. So it's mainly acts on the downstream pathway, much above the VEGF inhibitor, where the VEGF inhibitors are acting. So thereby acting on the tumor angiogenesis, relying on the interaction between endothelial vascular growth factors, which can activate P13K, AKT, mTOR in the endothelial cells, pericytes, and cancer cells. So this is what I was talking about. mTOR inhibitors are acting on a much lower ladder in the tumorogenesis. Here the lenvatinib acts FGFR and VEGF pathways, inhibiting the RAS, RAF, MEK, downstream pathway, and again P13K, AKT, mTOR. S6K, S6. So you can study it from the standard textbooks. And here you can see from this blue line, everolimus is acting on the downstream pathway. The RAS as well as PI3K pathways you have to learn from the textbooks. It is important for the exam point of view. The mTOR pathway is inhibited by the everolimus. It's a much acting at a much lower level. It's a so if you are, the problem with the everolimus using alone is that if you are acting only on mTOR, the resistance develops very rapidly, and the PFS attained is very low. But when we are using a combination Lenvima and everolimus, it is acting at a higher level as well as a lower level. So the RAS downstream pathway as well as the PI3K pathway, both are inhibited simultaneously, in addition to the mTOR inhibition given by everolimus. This HOPE study was presented in the Lancet. After this, lenvatinib everolimus was approved by the FDA. The eligibility criteria was metastatic, advanced and metastatic RCC, measurable disease, progression on at least one prior regimen, progression within 9 months of stopping prior treatment, and ECOG 0 or 1. Lenvima is used at the dose is very important because a few studies have used 24 milligram. So in the combination, we are using at a lower dose 18 milligram and everolimus at 5 milligram. And the single agent, we are not discussing it anymore because the combination is much more effective. Everolimus alone is used at the characteristic breast cancer dose, that is 10 milligram OD dose. So what is the primary endpoint? Primary endpoint is PFS. Secondary endpoints are response rate and OS. And you can see from this chart that both the arms are equivalent. If you are seeing the median age as well as performance status and calcium levels is more or less the same, and 86% of the combination arm had prior nephrectomy compared with 96% of the everolimus arm. What about the poor risk category? Because that is very important, because poor risk are faring dismally if you are using sunitinib and pazopanib in the first line, that we have already seen. So this arm is also containing 39% of the poor risk patient compared to 38% in the everolimus arm. And the metastatic sites were also equivalent in both the arms, more or less the same. So if you are seeing the PFS curve, 14.6 months with the combination versus 5.5 months in the everolimus alone arm. So you can see that at the end of 2 months, the curves are separating, and they continue to diverge. So the curves are not coming nearer. It is getting diverged away from each other. That means the more you are taking the drugs, the PFS is maintained, and the other arm is not doing that well. This is what I was talking about. If you are using everolimus alone, since it's a downstream molecule in the angiogenesis pathway, the resistance is developed very rapidly. So you can see if you are using everolimus alone, even with 10 milligram dose, the PFS is very less. You can say that probably the patient will have a progression-free survival of around 6 months. But when you are using the combination, you can see the hazard ratio is very impressive with a significant p-value. What about the OS? OS is also improved, 25.5 months versus 15.4 months. You can see that the curves are separating, but the p-value is borderline. So you can see from this, it's a busy slide. You can see that overall response rate is also very much improved, 43% with the combination arm, with only 6% in the everolimus arm. Confirmed responses, 37% versus 6%, CR 2%, CR, that too in the second line, is very important. What about the partial response? 41%, stable disease 41% in the combination arm. You can see from the other side that if you are using everolimus alone, you are getting a stable disease in as the commonest response, and the duration of response 13 months versus 18.5 months, 8.5 months. So you can see from the slide that this combination is very much superior to everolimus alone. What about the side effects? That is very important, because both the molecules have got their own class side effects. Everolimus causes mucositis, diarrhea, and lenvatinib can also cause diarrhea, hypertension, because it's a VEGF inhibitor. This slide is important. It is not a very cool regimen. It has got its own side effects. You can see that grade 3 diarrhea is seen in 20% of the combination arm, and grade 3 fatigue is seen in 14%. Decreased appetite is seen in 6%, and hypertension 14% grade 3, and nausea 6%, and hypertriglyceridemia, that is mainly caused by everolimus. You can see that 8% in the combination arm, 8% in the everolimus arm. Though it's toxic, it is a tolerable regimen with adequate physician attention. You can continue with this regimen. It's a highly potent regimen. So if you are seeing the latest NCCN, all the three molecules, all the three combinations that we have discussed today, cabazantinib, lenvatinib, everolimus combination, as well as nivolumab, all these combination improves the OS. So in the second line, OS is very important. So all these molecules have got, all these combinations have got a regimens have got a category 1 recommendation. So what about the re-challenge? After this regimen, so how will you sequence the second line and beyond? So this is another phase 2 study of lenvatinib. Here we have used 20 milligram lenvatinib plus pembro 200 milligram every 3 weekly. Clear cell RCC alone were included, and progression after immunotherapy. So you are re-challenging again with the immunotherapy. Again, the response rate is the primary endpoint here in this study. So you can see that prior nephrectomy was done in 75% of the patients, and 22% of the patients were MSKCC poor risk, and PD-L1 was positive in 42%, and 16% it was not available. So 39% of the patients have received one line, 61% have used more than one line, and 37% have used Nivo-EP combination, and 65% use IO-TKI combination. This is mainly contains patients who have used who are taken more than 2 lines. Here you can see that 61% of the patients have received more than 2 lines. Here you can see that still you are getting a 51% overall response rate, and 5% have progressive disease, and you are getting an impressive 1 year as PFS, and 77% of the patients are surviving 1 year. This is also another study, very recent. So salvage ipilimumab and nivolumab after first line, after use of immune checkpoint inhibitors. Here the 89% were clear cell carcinoma, and mainly 20% favorable risk group and 64% intermediate risk group. So you can see that the number of lines of treatment. Most of the patients, only 2%, only 20% received only 1 line, 27% 2 lines, 18% 3 lines, and more than 4 lines, 22%. So heavily pre-treated population, you are re-challenging with the Nivo-IP combination. So what about the overall response rate? 20% overall response rate, median PFS of 4 months, duration response 7 months, and response is seen in prior IO-VEGF inhibitor usage also. So what this last 2 studies what we have discussed is that suppose if you are using everolimus and lenvatinib combination in the second line, you can re-challenge with immunotherapy in the third line. So that will sequence our first line as either pembro axitinib or nivo-cabazantinib, followed by a lenvatinib and everolimus second line, and again immunotherapy re-challenging. That will be an excellent sequencing in the current scenario. The other option is that if you are not using cabazantinib in the first line, you can use cabazantinib in the second line, again re-challenge with immunotherapy in the third line. That is also acceptable if the patient is frail, and if you are worried about the side effects of the everolimus lenvatinib combination. So you can, if it's a frail patient, if you are worried about the side effects, then cabazantinib in the second line is also an option. But if you are seeing the excellent PFS as well as OS achieved in this study, HOPE study, you can see that the lenvatinib and everolimus combination is a much powerful second line in those who can tolerate double agents. So evidence suggests that, to summarize today's presentation, excellent activity of TKI regimens in the second line. TKI based combination is promising and has the potential to Lenvima based combination is promising and has the potential to become the new standard of care in the second line after TKI failure. And cabazantinib and nivolumab are proven to be excellent other options because they improve the OS as well. If you want to use a single agent, these are the alternatives. And sequencing of the therapy remains a standard of care in the current first line IO regimens. And however, the standard treatment is not defined. So currently, it is all left to the physician to use these agents, how to sequence them, and how to choose the second line as well as third line. But in the presentation, we have discussed what are the options, how to sequence, and what are the results you can assume to get. Immunotherapy re-challenge is possible. that we have seen in the last two studies in today's presentation after failure of first line blockade. And optimal sequencing regimen again has to be defined, but we have discussed the possibilities. Thank you. Any questions, or can we wind up?
Yeah, so if there are no more questions, thank you so much, sir, for such an elaborative discussion on the management of ARCC second line and beyond. And I think you have cleared all the doubts and you have presented all the agents which are now approved as a second line treatment option for the management of advanced RCC. Thank you so much, sir, for giving your time and taking us through the developmental part of second line agents in ARCC management. And on behalf of Isai Oncology, we wish you a very happy weekend and be safe. And in future also, we'll have some more scientific interactions with some different topics. Thank you so much, sir.
Okay, bye. Okay.